All right, let's go ahead and get started here. So welcome to the April Radicle Community webinar. My name is Timothy Byars. I'm the president of Radicle Health, and I'm also joined tonight by our CEO, Eloise Theisen. So these webinars are included in our community membership package. They're free to all of our members. They're free to the general public. The Radicle community is comprised of advocates and educators and healthcare professionals and cannabis stakeholders, and we intend to provide support and information and resources to our members. So for information about how to join, just go to our website, radiclehealthcare.com, and click on the community link. When you sign up, you receive access to, we have some newsletters that we've put out. We have our on-demand video library, which includes recordings of all of our webinars that we've done, as well as additional interviews and other media. And it's free to sign up. There's no cost associated with joining. It simply adds you to our email list. So I do want to remind everyone before we get started that we have an array of curriculum options at a range of price points for students and working professionals. You know, whether you're helping customers make good product choices, or if you're treating patients, if you're advocating for social change, or maybe you're just using cannabis yourself, you need evidence-based factual information about cannabis. A Radicle Health curriculum is up to date, it's comprehensive, and it's informed by clinical experience and expertise, and also instructional design expertise. So just reach out to us for information. You can go to our website, click the education link, or you can go to our Thinkific website, and the URL is there at the top. So today, the presentation is for educational purposes only, and the information presented today is not intended to be a substitute for medical advice. This information is not meant to help in the diagnosis, prognosis, or treatment of any virus, disease, illness, or condition. If you join this webinar because you are presently experiencing adverse effects from THC overconsumption, I recommend that you settle in, because we're not going to actually get to recommendations for another 30 minutes or so. So hang in there. So today is kind of a fun talk. I mean, unless you're going through it presently, but it's kind of a fun talk. We're talking about THC overconsumption and antidotes to overconsumption. So acute THC overconsumption incidents, we all know that they typically involve THC or THC-infused cannabis or cannabis products. Often they're in the form of an edible. These incidents usually consist of panic reactions, sometimes toxic psychosis, but they usually resolve without treatment, right? There's usually no pharmacological intervention that's generally necessary. Typically, all that's needed is time and comfort and supportive counseling and reassurance, and these are usually sufficient for resolution. For anyone who's ever experienced acute THC overconsumption, that previous description probably fails to capture the fear and unpleasantness associated with these experiences. And we're not going to address severe THC overconsumption today when hospitalization is required. But cannabis consumers who have had this experience know that it can feel like you're going to die. And that's not hyperbole. So I'm going to talk a little bit about the history of using antidotes for THC overconsumption. And for that first part of the history talk, I'm going to lean kind of heavily on Ethan Rousseau's paper called Taming THC, Potential Cannabis Synergy and Phytocannabinoid Terpenoid Entourage Effects. It's a good paper. It's kind of old now, but if you're not familiar with it, you should be. So it's free online, and you can go ahead and read it there. But historically, there's been a lot of speculation and assumptions about whether and how various components of cannabis and other compounds can attenuate THC overconsumption. So in the 1st century, Pliny the Elder described cannabis as leaves of laughter, but he also suggested that it can produce phantoms that beset the mind. His remedy was to eat pine nuts with pepper and honey in palm wine. Now, we'll talk about pepper and pining a little bit later, but the alcohol is interesting here. We know that alcohol can actually potentiate the effects of THC, but ancient wines were not like the wines that we have today. They were often stored in clay pots, and the clay pots were lined with pine tar, or terebinth resin. Terebinth trees are also called turpentine trees. And pine tar contains, of course, high concentrations of pinene, and so does terebinth, and terebinth also includes limonene. There's a very old Persian remedy of cannabis overconsumption. It translates to, quote, "To avoid the harms from ingestion from hashish, one should drink fresh water or eat any acid fruits," end quote. If this advice is about 1,000 years old. Lemon or lemon water with a rind has been suggested as an antidote to THC overconsumption since the 10th century. In the Ayurvedic tradition of India, calamus root is suggested as the best antidote for adverse effects of cannabis and hashish. Some texts suggest preventative measures by including a pinch of calamus root powder in with the cannabis before you smoke, and that's supposed to neutralize any adverse side effects. Calamus contains a compound that helps induce the production of acetylcholine, and this is a neurotransmitter that can help slow down heart rate and relax muscles. So today, if you search the internet for antidotes to THC overconsumption, you're going to find a pretty wide variety of suggestions, and they include take a hot shower, take a cold shower, mix a couple of teaspoons of sugar and put in an 8-ounce glass of water. It's very specific about the size. Eat food, drink lemon juice, drink water, drink herbal tea, sniff black pepper, chew black pepper, go to bed, take a walk, get fresh air, talk to someone, distract yourself with something familiar but unchallenging, something like a favorite movie or a video game, take CBD, take ibuprofen. And my favorite, avoid getting too high. So, do any of these work? We know avoid getting too high works, but what about the other ones? So we decided that we wanted to take a look at the existing medical literature, consider the information that we have about human physiology, and provide some recommendations that are evidence-based. And mostly we're going to focus on whether CBD can help mitigate or reverse THC overconsumption, but we're going to come back around at the end of the talk and look at some of these other suggestions as well. So when we explore whether CBD or other individual compounds in cannabis or just other compounds outside of cannabis can mitigate the adverse effects of THC, what we're really discussing here is entourage effect. So within the context of entourage effect, there are 3 mechanisms by which compounds can interact. And these are examples that are from Michael Tagan's website, Prof of Pot. So if you don't know Michael Tagan or Prof of Pot, it's kind of a silly name, but it's a great website. So definitely a good resource and you should check it out. So these are the 3 mechanisms. The first one is pharmacokinetic interactions. So these describe when a molecule impacts the concentrations of a second molecule in the brain or in the bloodstream. The second one is direct pharmacodynamic interactions, and these describe when a molecule modulates the effects of a second molecule by binding to the same receptor. And then the third one is indirect pharmacodynamic interactions. And this describes when a molecule modulates a second molecule by binding to a different receptor. So we're going to take a look briefly at each one. So the first one, pharmacokinetic interaction. So during this kind of interaction, you have one molecule. So in our case, we're going to focus on CBD. Is affecting some process of the absorption, the distribution, the metabolism or excretion of a second molecule. So in this case, THC. There is some evidence that in animal models that administering CBD before THC, about 20 minutes, can increase the levels of THC in the blood and the brain. We don't see any similar effect when they're co-administered. The data in humans is less clear. We can make some assumptions, however, based on data from animal models and based on our understanding of cannabinoid metabolism. So CYP2C9 is the primary enzyme responsible for the metabolism of about 100 therapeutic drugs, and it includes, it metabolizes blood thinners and also some non-steroidal anti-inflammatory drugs. And this enzyme metabolizes both THC and CBD, but it's the primary enzyme for the metabolism of THC into 11-hydroxy THC. And research suggests that CBD is a potent inhibitor of CYP2C9 activity. So just as a reminder, when a substance inhibits a CYP enzyme, that substance decreases the enzyme's activity. So inhibition of a CYP enzyme is instantaneous, and we can it can immediately exaggerate the effects of any subsequently administered drugs. So if you administer CBD prior to THC, it's possible that a larger amount of THC will be available to the bloodstream and will remain in the body for a longer period of time. Now, the effect will likely depend on the dose of CBD, the cannabinoid ratio, and also the timing of the administration. So the second type of interaction that we have is a direct pharmacodynamic interactions. So during these types of interactions, you've got, again, two molecules, let's say THC and CBD. They're both attaching to the same receptor, although they don't necessarily have to attach to the same receptor site or to the same type of site. So recall that there are main binding sites on cells called orthosteric sites, and there are second binding sites on cells called allosteric sites. Allosteric substances don't bind to the main binding site. These substances bind to the secondary allosteric receptor site, and they subsequently change the shape of the protein and of the orthosteric site as well. So there are three different categories of direct pharmacodynamic interactions, and they can be classified as either additive, synergistic, or antagonistic. So we're going to look at those three also. Additive interactions. These occur when two molecules act on the same receptor in the same manner. So imagine that you have two agonists, for example. That would be an additive interaction. If we want to try to find an example for THC and CBD, they're both negative allosteric modulators at the 5-HT3A serotonin receptor. So this is an example where it doesn't really matter how much of each compound is interacting with the receptor. You could have 5 milligrams of THC and 5 milligrams of CBD, or you could have 10 milligrams of CBD. It would produce the same effect. The second type is called synergistic interactions. So these occur when you have a combination of molecules, and there's an effect that's greater than the simple additive effect of each molecule. And I want to propose that most people, especially people in the cannabis space, when they think of entourage effect, this is what they're thinking of. They're thinking of a synergistic interaction, chemical compounds in cannabis working together to produce a synergy of benefits greater than the sum of the parts. The first example of this is by the two men who coined the term entourage effect. It was in 1998. It's Raphael Mechoulam and Shimon Ben Shabbat. And they demonstrated that there were these esters that they were looking at, and the esters had no binding affinity for cannabinoid receptors, but they significantly potentiated the binding of the endogenous cannabinoid 2-AG at both cannabinoid receptors, CB1 and CB2. And they referred to this relationship as entourage effect. In 2016, there was a private company that reported finding 8 terpenes and 3 cannabinoids that increase the potency and effects of THC at CB1. And if this research is confirmed, and I haven't seen any published data since the original press release of 2016, we have to assume that the results will likely be demonstrated through a positive allosteric modulation. And then the third type of this kind of interaction is called an antagonistic interaction. So these occur when a molecule inhibits the effects of a second molecule. So for example, you might have antagonistic interactions if you have one molecule that's an agonist at a receptor, and then you have a second molecule that's an antagonist at the same receptor. So the two molecules in this scenario would be competing for the same receptor site, competitive binding. Antagonistic interactions can also occur if you have one molecule that's an agonist and the second molecule is a negative allosteric modulator. So our understanding of the pharmacodynamics of CBD, of course, has evolved over the past 20 years. When you look at older literature, the research might suggest that CBD has no interaction with either CB1 or CB2. Subsequent studies will suggest that CBD is a neutral antagonist at CB1 with really weak binding affinity. And then in 2015, Robert LaPrairie and his team at Dalhousie University, they demonstrated that CBD is a negative allosteric modulator at CB1. And there are a bunch of CB1 receptor allosteric modulators, both positive and negative. And so you might assume if CBD is a negative allosteric modulator at CB1, it should negate or mitigate some of the effects of THC at CB1. And it does mitigate some of the effects of THC at CB1 through negative allosteric modulation. It's like a dimmer switch. But that's only one of the multiple manners that CBD will impact the effects of THC. And because CBD is a promiscuous molecule, the mechanisms and pharmacodynamic effects are nuanced and they're complex. So, for example, you can have direct pharmacodynamic interactions between CBD and THC, not only at CB1, but you can have these kinds of effects happening at other receptors as well. THC is an agonist at CB2. It's an agonist at GPR18 and GPR55. And CBD displays antagonistic properties at all of these receptors and inhibits the effects of THC at these receptors. We already talked about pharmacokinetic interactions that can occur. So again, CBD is an inhibitor of CYP2C9. And then we have the last type of interaction, indirect pharmacodynamic interactions that can also occur when you combine CBD with THC. But before I move on to the last indirect interactions, I want to pause here because on the slide I have a couple of illustrations. And both of the illustrations suggest an antagonistic relationship between CBD and THC at CB1. And I wanted to ask quickly to the audience, so if you want to answer, just unmute yourself. Which of these illustrations do you think is more correct? The one on the left or the one on the right? So there's one where CBD is in a green circle and it sort of looks like it's in the CB1 receptor. And then there's the one on the right where CBD is kind of a purple, two purple hexagons. Which one do you think is more correct? And you can put it in the chat, or you can unmute yourself and shout it out. All right, I've got a couple of votes for right side. Another right side. Yeah, that's correct. So when you look at these two illustrations, the one on the left looks like CBD is actually binding. It's inside the receptor site. And obviously these are very simplified illustrations, but it looks like CBD is in the receptor and it's physically blocking THC from binding to CB1, and that's not really the way it works. Remember, it's a negative allosteric modulator. So it binds to the protein at an allosteric site, at a secondary site, and it actually changes the shape of that protein in a way that will eventually change the shape. This is oversimplified also. It actually happens through a wave, but it changes the shape of the orthosteric receptor. And so THC doesn't bind as well to the shape when CBD is there as well. So just wanted to cover that before we moved on. All right, the last type of interaction. It's probably the most important type, especially for our discussion today, and it's called indirect pharmacodynamic interaction. So this kind of interaction occurs when two or more molecules influence others via different receptors. So CBD has non-cannabinoid receptor mechanisms that also likely impact the pharmacodynamic effects of THC. For example, it's a potent agonist at 5-HT1A receptors, so is CBDA. 5-HT1A receptor agonists can help relieve anxiety. We know that when mice are bred without these receptors, they demonstrate an increase in anxiety-like behavior. And we also know that there are some clinical studies that suggest that patients who have panic disorders have impaired 5-HT1A receptor function. We also know that CBD can lower blood pressure, probably through 5-HT1A activation. And overactivation of the CB1 receptor, we know that it produces anxiety, and the activation of 5-HT1A receptors might help mitigate those effects. So the anxiolytic effects of CBD, or really any substance, whether it's caryophyllene or limonene or linalool, any compound traditionally used to mitigate THC overconsumption, likely mediated through this type of interaction. All right, so I know that was a bit heavy on the science, but I'm gonna turn it over to Eloise, who I think is going to illustrate some of these concepts with references to some studies in the medical literature.
Thank you, Tim. Do you want to see if anybody has any questions really quickly on any of that, just before they forget it?
Great idea. Any questions?
I always love learning about it because I feel like it's information that needs to be reinforced quite consistently.
I think so too.
All right, go ahead. Oh, sorry. I was just gonna say next slide, Tim, if you don't mind, please. All right, super. So I want to talk a little bit about the adverse effects of THC, which Tim did a really nice job of in the beginning. And remember that THC is biphasic. Most cannabinoids are known to be biphasic. I'm going to pause for 1 second. The dog was about to bark. So we know that THC can be biphasic. Low dosages may be very helpful for things like anxiety. They may help us sleep. They may help with nausea. And then we get to those higher dosages. It can include adverse effects such as anxiety, hallucinations, paranoia, and forgetfulness. And this is often where people want to find an antidote for those effects. Next slide, please. The psychoactive effects of CBD can also be biphasic with different effects at low dosages other than high dosages. We know sometimes low dosages can improve concentration, it can work as an anti-anxiety and an antipsychotic agent, and some of those are in larger dosages. Next slide, please. So in looking at how often I hear people talk about if you get too high, just use CBD. I've heard people say, smoke some CBD, take some CBD. And I really wanted to look and see what does the research say? Is it accurate for us to be telling people to use CBD as an antidote for too much THC, excuse me. So looking at some studies here, and this is from McPartland. He really did a nice job of putting these studies together. And yes, these slides will be available for you. What's really important to know is that you can see here, if you can read it, CBD does decrease THC suppression of behavior in rats. It can potentiate THC-induced changes in hepatic enzymes. CBD can increase THC potentiation. CBD can increase THC reduction of intestinal motility. CBD can reduce THC hypothermia and bradycardia. So you can really see in the animal studies, when you get to the human studies, you can see that CBD decreases anxiety caused by THC. Now this is back in 1974. CBD can slightly increase time to onset, intensity, and duration of THC intoxication. THC attenuated THC euphoria. CBD reduced anxiety provoked by THC. CBD improves sleep and decreased epilepsy. CBD decreased cortisol secretion and had sedative effects, and CBD provided antipsychotic benefits. In 2010, there was research demonstrating again in humans that higher CBD to THC ratios correlated with a decrease in memory and cognitive deficits. And in 2011, we saw higher CBD to THC ratios correlating with less psychiatric symptoms common in high THC. Starting in 1974, Brazilian researchers tested oral doses of THC up to 30 milligrams and CBD doses up to 60 milligrams in varying ratios in 40 male subjects. And they stated, quote, CBD also changed the symptoms in such a way that these subjects receiving the mixtures showed less anxiety and panic, but reported more pleasurable effects, end quote. Next slide, please. And the research goes on, and this is a little bit more recent. Again, you have some animal studies, but the human studies really did demonstrate that CBD can reduce THC intoxication and impairment. CBD counteracted THC somnolence and morning after memory deficits. High THC cannabis with higher dose of CBD caused less anxiety than just high THC alone. CBD reduced anxiety. CBD reduced psychotic scores of THC. CBD attenuated the appetitive effects of THC. Increased CBD to THC ratios in chronic cannabis users correlated with a reduction of cognitive and memory deficits. Increased CBD to THC ratios in chronic cannabis users inversely correlated with liking for drug-related stimuli, including food. Increased CBD to THC ratio is associated with lower degrees of negative psychiatric symptoms and no difference in side effect profiles between cannabis extract and THC alone. I think you're starting to kind of get the picture here. Next slide, please. And again, more animal and human studies demonstrating how CBD can potentiate THC's negative effects. And they did some studies, of course, on Sativex, which is the 1-to-1 out of the United Kingdom, which is 2.5 milligrams of CBD and about 2.7 milligrams of THC in an oral mucosal spray. And in these studies, they found that Sativex compared to THC alone produced greater pain relief and improvement in sleep. Sativex compared to THC alone improved cancer-related pain, and compared to THC alone, Sativex reduced abnormalities and psychomotor performances associated with schizophrenia. In a 2005 study, it suggested that CBD can antagonize some undesirable effects of THC, including intoxication, sedation, and tachycardia, while contributing to analgesia, antiemetic, and anti-carcinogenic properties. Additional studies suggest that higher CBD to THC ratios antagonize THC's effects, but a 5-to-1 CBD to THC potentiated THC's effects. So very interesting here. It really, I think the research has demonstrated that the higher the CBD and the lower the THC, the less likely you're going to feel some of those anxiety type effects that can come from THC. And more studies confirmed that the co-administration of CBD counteracted the psychomimetic and psychotropic effects of THC. So we continue to see these results in multiple studies. Co-administering CBD and THC seems to attenuate the effects of THC, especially doses of a 6-to-1 ratio or higher. Next slide, please. And again, looking at using CBD and THC together seem to show a higher or a better outcomes, especially when you look at providing pain relief and improvement in sleep. Next slide, please. And again, CBD and THC combined compared to just THC alone seem to improve cancer-related pain. Next slide, please. So CBD's effects on THC, you have 3 different effects. Again, Tim talked about this in the beginning, and you have the pharmacokinetic interactions, again, the inhibition of that CYP2C9, the direct pharmacodynamic interactions. So we know that CBD can have low affinity at CB1 and CB2, and is a negative allosteric modulator at CB1. And again, those indirect pharmacodynamic interactions augmenting our anandamide levels, inhibiting adenosine uptake, and it's an agonist at that 5-HT1A. Next slide. So what is most important really is timing. When we are going to administer CBD, if it actually is going to counter affect the negative effects of THC, when do you administer it? Is it before, during, after? Well, the research actually shows that it should be co-administered, and timing is really important. There's some literature, as Tim said, of course, in animals, that if you administer it before, it may actually increase the effects of THC, especially that 11-hydroxy-THC, which in animals was shown to be 4 times more potent than THC. So it can be a much more impairing effect. And we definitely need more research around CBD's modulating effects on THC's metabolism. But for now, if we really want to help reduce the negative effects of THC, the recommendation is to use it together in those ratios that we talked about. And Tim, I think you added some of these in, so I was hoping you were going to touch on them.
Yeah, so there are a couple of commercial products that claim to be THC overconsumption antidotes. This is the first one. This is called Canna Relief, and this is a hemp-derived CBD product. It's, I think there's 20 milligrams of CBD in the bottle. It also includes water, sugar, vitamin C, something called guayusa. I'm probably pronouncing that incorrectly, but that contains caffeine, citric acid, and vitamin B12. So it's a dose of hemp-derived CBD. There's another one called Buzzkill. This product basically has every ingredient ever suggested to counteract THC overconsumption. I think that they just threw them all into the product and hoped one would work. It's got over 20 ingredients. It's got calamus root, lemon peel, black pepper, lavender, ginger, cinnamon, mango, lemongrass, orange peel, chamomile, cardamom, echinacea, rosemary. No cannabinoids though. So that's one interesting thing. So two products that are out there that are commercially available for THC overconsumption. What we really need is a good neutral antagonist or safe inverse agonist at CB1. And we have a good example in the opioid world, right? We have Narcan or naloxone, and that immediately reverses an opioid overdose. It works in like 2 to 8 minutes. And naloxone is an opioid receptor neutral antagonist. It competitively binds to the same receptors as opioids. This is direct pharmacodynamic interaction. And it was designed, naloxone was designed to have a much higher affinity than opioid drugs at opioid receptors. And naloxone can therefore displace the opioids at the receptors and immediately reverse the harmful effects. And there are certainly CB1 antagonists and inverse agonists that exist. In fact, there's been a lot of research in a number of synthetic cannabinoids that were developed, or compounds that were developed for CB1 antagonism. Now, recall that CB1 receptors can stimulate appetite. So the thought is blocking these receptors, especially with an inverse agonist, can lead to a decreased appetite. And the driven largely by the search for an effective treatment for metabolic syndrome and obesity, most cannabinoid receptor 1 research has focused on decreased consumption and satiety research. They're looking at weight loss. However, these compounds can be useful in the search for treatment for acute cannabinoid overconsumption as well. And most of them come from the same family of synthetic compounds. I don't know what they're called, but I call them the Abants. And the first one is Rimonabant. Probably most of you have heard of Rimonabant. It was approved for use as a weight loss drug in Europe. It was removed from the market in 2008 due to severe psychiatric side effects like depression and anxiety and suicidal ideation. There was another one called Serinabant, also discontinued by the manufacturer due to severe psychiatric side effects, such as depression and anxiety and suicidal ideation. The CB1 receptor does a lot of things besides stimulate appetite. For example, it also impacts our mood. So when these things happened, it sent a chill through the research community, and a lot of these the research promptly stopped. So you also had Taranabant. This was in phase 3 clinical trials, discontinued in 2008. Rozanabant, discontinued in 2008. Otenabant, research suspended in 2009. And Drinabant, research discontinued during phase 2 clinical trials in 2009. And when you have a company that gets to clinical trials, they've invested a lot of money into these drugs. And so these are difficult decisions for them to make. And by the way, these were really effective at treating obesity and facilitating weight loss. And there are many, many others that have been tested and that are still being researched. In fact, one of the Abants seems to have survived. In 2018, Drinabant was licensed by a company called Opiant Pharmaceuticals, and they intend to develop it for treatment of acute cannabinoid overdose as it's an injectable for administration in an emergency department setting. So, help is coming, right? So there are some things that, at least in a hospitalization scenario, where we're probably going to have something that we can use, which would be really effective and helpful for for example, when toddlers accidentally ingest too much THC. And incidentally, the effects of overconsumption of THC in very young children can be the opposite than that of adults. It can actually suppress the respiratory function in toddlers. So really important to have something like an inverse agonist or a neutral antagonist as an antidote to THC overconsumption. So help is coming. That doesn't help us now. What do you do if you have taken too much THC? Or maybe you're a nurse and you work for a hotline, and somebody calls you up. What kind of advice do you give them if they have consumed THC. So I thought maybe we can go through each one, and I'll ask Eloise what she thinks, and if I have anything to add, I'll throw in my 2 cents as well. So let's start with this one. Eloise, what do you think? Hot shower. Take a hot shower. Take a cold shower.
Well, I always find that warm water helps me with my anxiety. So I would say yes to the hot shower to help relax me. The cold shower might snap you out of it, but would be a little bit of a shock. And there is some evidence that it can help upregulate your endocannabinoid system. I don't know if that would be the smartest thing to do when you're in the middle of a THC overconsumption episode.
Yeah, I think this might be an activity that maybe is inherently calming. If it's a hot shower. If it's a cold shower, then very mentally alerting. The one thing I was thinking about is that, hot water, of course, might activate TRPV1, and TRPV1 can produce anxiety. You'd have to take a pretty hot shower. I think that they don't activate until like 109 degrees Fahrenheit. But this probably is just something that maybe is inherently calming, and probably not a lot of medical literature to suggest that this actually works. But if it's calming for you, then maybe we'll give that maybe 1 thumbs up, 1 thumbs down for that one.
It was what we used in the pandemic early on to help us cope was hot showers.
All right, how about this one? Eat food.
Well, there's some research to demonstrate that having food will help decrease some of the side effects, but does eating afterwards actually make any difference? Probably not.
Yeah, I think this one probably arose from, someone is mentioning fatty foods. This probably arose from what kind of absorption do you get in a fed state versus a fasted state? I think, as Eloise said, I think timing is probably pretty important. If you're using edibles with CBD, you should probably consume your edible after a meal. But if you're already too high, that's too late. But in a fasted state, CBD does absorb pretty poorly, more poorly than in a fed state. So it would throw off the ratio of THC to CBD, right? But I think for the most part, I'm going to say probably not helpful, again, unless this is something that's calming.
Yes, and fatty foods exactly will increase the bioavailability and make it much more potent.
Yeah, good point. How about this one? Chew or sniff black pepper?
Okay. So are we lining up rows of black pepper and snorting it? I've heard some people, have had some success with it. We know that beta-caryophyllene can have great anti-anxiety effects. So is it actually, having any effect on the THC, or is it just calming us down?
Yeah, this suggestion is probably the most widely and zealously repeated antidote to THC overconsumption. I'd say second only to taking CBD. We do know that black pepper contains caryophyllene. It's a CB2 partial agonist. CB2 activation can produce some anxiolytic effects, maybe counteract the THC-induced anxiety through indirect pharmacodynamic interaction. I actually had an opportunity to try this one out this week. I'm taking experimentally high doses of CBD, and I made a rookie mistake. I was switching to a new product, and I took my dose of CBD. It's an infused product. And I didn't check the COA prior to taking a dose, rookie mistake. And because it's an infused product, whole plant product, it had some THC in it as well. And because my dose was so high, it was enough to produce some psychoactivity. So I said, aha, I can test one of these antidotes out. And I thought I would test out the black pepper. So I do have some recommendations. First, please don't sniff ground pepper unless you would like to introduce a sneezing fit. Second, black pepper kernels are really intense. So if you intend to chew them, just chew one, don't chew a handful, because they're very, very intense. And then I also sort of breathed in the kernels. I can't say that any of those things were helpful. Um, I'm not questioning the science that, again, this is a beta caryophyllene is a partial agonist at CB2, and we do know that that can produce anxiolytic effects, but I don't think that the dose that you're getting of caryophyllene from sniffing, wafting your nose over black pepper kernels or even chewing on a kernel is probably going to produce enough beta caryophyllene to make a difference. All right, how about this one? Go to bed.
Well, I mean, I don't know. I've had some really intense THC overdoses, and the last thing I can do is get my mind to calm down to go to sleep.
Yeah, so I've done this before. It can backfire, right? So THC overconsumption requires sometimes that you get out of your own head, and going and lying down in a dark room is not a good strategy for that. But if it relaxes you and it feels okay, again, nothing in the medical literature really about sleep and overconsumption. But if it's a calming thing, then I'd say go for it.
Some people do find that too much THC just makes them incredibly drowsy and sleepy, and they can go to sleep. But if you do lay down,
absolutely,
yeah, like you said.
Somebody had a question about caryophyllene. What about essential oils high in beta caryophyllene? It's a good question. If you have something that's consumable that's really high in beta caryophyllene, again, it is backed by medical literature, so I don't know what kind of dose you would need to actually produce an effect. So you might need to do some experiments on your own.
Oil. Yeah, we did have some cannabis nurses at a conference before they went on stage to give their presentations taking beta caryophyllene in an essential oil. They were doing about 150 milligrams to help calm them down. So that was their anecdotal observational reports.
That's a fairly high dose.
Mm-hmm. You're not going to get that in sniffing black pepper, probably.
No. All right, how about take a walk, get fresh air, exercise?
Well, the TikTok video that I watched yesterday of the guy that had overconsumed, his legs were jelly. He couldn't even move. So, it really depends on, I think, the effects that you're feeling. If you can get out and get some fresh air and you feel safe on your feet, absolutely. But I also worry about people feeling unsteady or off balance and putting themselves at risk for a fall.
Yeah, and don't wander off by yourself either.
Yeah.
Drink something: lemon water, herbal tea, sugar water.
I think it's interesting to look at the history going back 1,000 years with lemon water or citruses to help. I think hydration is incredibly important if you're using any kind of cannabinoids, particularly THC, because it does have anticholinergic effects. So water can not only be calming, but it can relieve some of the incredibly intense dry mouth or cotton mouth that people might be experiencing. But will it counteract the THC high? I'm not sure.
Yeah, again, a lot of these compounds, limonene, or herbal tea, the compounds that are in herbal tea, possibly producing anxiolytic effects. There's not really a whole lot of limonene in lemon juice. It's usually in the rind. It's in the essential oil. I don't know how pleasant it would be to zest a lemon and then drink it in water. But it might help produce indirect pharmacodynamic interactions if you're experiencing anxiety. I don't know, but it might also just be calming to have a glass of tea or a cup of tea. Don't drink alcohol. It will probably potentiate the effects of THC. Talk to someone, distract yourself with something familiar but unchallenging. Your favorite movie, a video game.
I think that could be something that would be really helpful. I think, often when people are experiencing, like you mentioned in the beginning, that THC effect, sometimes you really do feel like you're dying. It's a miserable experience. And having someone who's experienced to hold your hand and talk you through it and just remind you that everything's okay, you're going to be okay, and it's going to pass, can really help people feel less anxious and not go, hopefully, to the emergency room.
Yeah, I think these are effective strategies for developing supportive set and setting. You know, you have counseling, you have reassurance. I think that's probably the big thing here.
Mm-hmm.
Take ibuprofen.
I had, early on was helping some cancer patients who wanted to use high dosages of THC to treat their cancer, particularly glioblastoma patients. And one of the patients, when he would take THC, obviously, even in small amounts of 25 to 40 milligrams, experienced some pretty intense psychoactive effects. So his son decided to take that dose. And then he went through all of these different things that the internet said to do and experimented once he got too high. And he said the only thing that he felt like helped was ibuprofen. And I think, Tim, you have a really good explanation as to why that is possibly going to help.
Well, it has to do with COX-2 inhibition, mitigating the effects of very, very high doses of THC. So it comes from a single study in mice. It was in 2013. They were administering 10 milligrams per kilogram body weight in mice. They were doing that once a day, and they did it for 7 days. And just to back up, so to provide some context, COX is an enzyme. There are two types. There's COX-1 and COX-2. And both of the enzymes, when they're activated, they promote inflammation and pain and sometimes fever. And there are medications that can inhibit the production of COX enzymes and relieve the inflammation. That's why we take non-steroidal anti-inflammatory drugs. Ibuprofen, for example. It provides relief by inhibiting these COX enzymes. So this study was really suggesting that COX-2 inhibition might help with the effects of long-term THC exposure. And it was mostly around memory impairment, not really about psychoactivity. And the study also suggested that if you're going to benefit from ibuprofen and THC from that combination, they should be co-administered. So I'm going to give this one a thumbs down, not because I don't think it, I think there's some promising research there around COX-2 inhibition and long-term THC exposure. But I don't think that you're going to benefit from this combination if you have symptoms of overconsumption.
And I think June makes a really good point, which will help lead into our next slide. And that's, doesn't ibuprofen take a while to take effect? Yes. So, if you're trying to use it to help counteract it, sometimes by the time that ibuprofen starts working, your THC overconsumption effects are probably starting to wane and wean down, which leads us to taking CBD.
The most popular one, CBD. What's your final conclusion on CBD?
Well, I never want to dismiss people's personal experiences if something has worked for them. And I've certainly had people tell me that taking CBD after THC overconsumption has been beneficial. But I would say that the research does not support using CBD as a THC antidote after the fact.
Yeah, so when you look at the research, and we looked at a fair amount of studies earlier, we know it has antipsychotic effects, right? Clinical studies that demonstrate that. We know it can reduce psychoactive effects, but only if it's co-administered. We don't see the same impact if it's administered afterwards. We know it can mitigate anxiety, right? So I think maybe if you're having some THC-induced anxiety, and you have a CBD product that has no THC in it, I think it's safe to go ahead and try it. It might help reduce the anxiety, but that has nothing to do with CB1 activation. Again, that's looking at indirect pharmacodynamic interaction facilitated by serotonin receptors, and dose is going to be important, and maybe the timing is important also. That takes us to this one, which is, don't get too high. The best way is preventative measures here. Either take some CBD with your THC dose, and the whole low and slow thing. Start with a very low dose, and make sure that you're if you're using cannabinoids as medicine, make sure that you're working with a clinician and you're dosing properly. All right, we have a couple of minutes left. Let's open it up for questions. And feel free to just unmute yourself. We'd love to hear from you, or if you want to just put it in the chat, you can do that too.